So I think it actually makes very good sense to have Lisa's talk first, because you could argue that if we've got the changes that are detectable with left atrial strain, and then later on what you end up with is changes in left atrial volume, then it's no great surprise, I suppose, that the increase of left atrial volume should then be something we can detect with mortality. So I'm going to go through a little bit about left atrial volume. You recognise this slide, which is exactly the same slide as Lisa put up. In fact, with exactly the same little drawings on it. So this is the part that I'm not going to go through is the strain measurement. But what I just wanted to point out is that it's actually at the maximum left atrial volume is where you would normally do this measurement to just get a static volume. So we're not talking about dynamic volume here. Purely from a static point of view, you want to get the biggest volume. This is there's a number of different methods of measurement of LA size. Now, those of you who've done echo for a long time will remember that the AP dimension used to be the only way we'd measure left atrial size. And I'll show you some data in a minute, because we've got lots of it in NEDA, that shows why it's really not worth your effort to measure left atrial dimension anymore. You can measure left atrial width and length, and you can measure area, but really those measurements mostly have their utility in actually giving you the left atrial volume or volume index. And exactly as Lisa said, this is a barometer of filling pressure. So if you imagine basically that you have an increase in the left atrial pressure that on average is higher than normal, then it's going to produce this stretch phenomenon that will end up causing a dilatation of the left atrium. So these are the normal ranges that have been published, and this is from the American Society of Echo publication. There's other publications showing the same numbers, and so normal is regarded as less than 34. The original publication on this showed less than 28, and I can show you from our data that there is actually a signal in both places, and I'll go through it in more detail. So there's a number of contributors to enlargement of left atrial volume: systolic and diastolic left ventricular dysfunction, and of course valvular heart disease. And they, if you put them all together, you can just say left heart disease is a major contributor. AF itself, so it goes both ways. So left atrial enlargement causes AF, but also AF causes left atrial enlargement. The athlete's heart has a chronic volume loaded state, or other causes of volume loading, and of course congenital heart disease is a myriad of things that result in left atrial enlargement. So I just want to go through a really simple way of looking at this. If you imagine that you've got a normal set of parameters, you've got normal left ventricular filling, you've got normal pulmonary veins, you've got normal pulmonary capillaries, normal pulmonary arterioles and arteries, and a normal right ventricle, then basically you've got an entirely normal circuit. So the left atrial volume will be normal, and there won't be any pulmonary hypertension. But if you then push everything up a notch or a few notches, and what you've got is you've got an enlarged left atrial, you've got an increase in left ventricular pressure, then chronically over time that results in an increase in left atrial volume. And sure, it responds to diuretics in that you can drop the pressure, but of course you're not changing the pathophysiology of the underlying disease, so you're not changing mortality. And so the pulmonary pressure rises in parallel, basically a one-to-one rise with the increase in the left ventricular pressure, but the pulmonary vascular resistance is normal in these people. And so really this, the method, I suppose, for left atrial enlargement here is around diastolic abnormalities. And this is just an example of a patient with diastolic dysfunction, and I won't really stress on that too much now. So in order to measure the relevance of an enlargement of left atrium, you've really got to understand the diastolic function of that individual. And again, I won't dwell on how to measure diastolic function, but suffice that E to E prime is probably the single most useful measure on trying to get a bit of a handle on why the left atrial volume might be increased. And of course, systolic heart failure is going to have a similar impact. And I'm sorry that the videos aren't continuing to play on this. This is from a kind of I suppose a snapshot from the Catherine Otto book chapter that we wrote on distinguishing causes of pulmonary hypertension. You can see here that there's left heart versus not left heart, inverted commas. So all the other causes of pulmonary hypertension, and so you've got pulmonary hypertension on both in both of these, but there are specific differences between left heart causes of pulmonary hypertension and non-left heart causes around diastolic function abnormalities, increased left ventricular mass, valvular heart disease. But relevant to today's talk is the left atrial volume index, and 34 mils per metre squared is that cut point. So you already saw from the previous talk about the angle dependency. This is the slide from the ASE guidelines, which is showing the difference. In the 4-chamber view, it's relatively straight, but in this particular example, in the 2-chamber view, you can see there's a clear angle between the left ventricle and the left atrium, and so you need to make sure that you're maximising the left atrial measurement, if that's, or the left atrial volume if you're measuring the left atrium rather than the LV. So there's nothing wrong with having an off-axis LV when you're measuring the left atrium. And one little trick generally is that your 2C, as in the 2-chamber, and the 4-chamber left atrial areas should be pretty close to each other. If they're generally within 10%, you know you're not far off. When you're doing the measurement, try to avoid the pulmonary veins. So you don't want to include those in the tracing, and you don't want to measure your left atrial appendage into it either. So you just sort of draw your line that goes over both of those. And also remember to measure at end ventricular systole. So you're measuring from the mitral annulus and from the midpoint of the annulus around the midpoint of the posterior wall, which is this red line I've got here, and exclude, as I said before, the left atrial appendage and the pulmonary veins, and do the same thing on both views. This is an example of 3D assessment, so you can see on the top is a normal left atrial volume changing throughout the cardiac cycle, and at the bottom is an abnormal tracing showing that there's really no change in the left atrial volume that happens throughout, and you can see that clearly this person has an enlarged left atrial volume as well. So there's multiple different ways of doing this. So, when you have an enlargement of the left atrium, on average, this predicts that there's pulmonary hypertension due to left heart disease. And here's an example using CT as well. So it's not just found with echocardiography. So now I want to move on to some really interesting data that we have from NEDA. So NEDA stands for the National Echo Database Australia. There's Jeff Strange and I are the two PIs for the study, and we have a steering committee of people that you would know well from around Australia. And basically where this came from was actually our original paper from 2012 that showed that, that pulmonary hypertension is common. And not only is pulmonary hypertension common, it's particularly common in echo labs, and most of it is due to left heart disease. So the minimum indicative prevalence of pulmonary hypertension is 3,500 per million patients, which is far, far commoner than it had ever been reported before. Now, we got a bit of flack for this because people said, oh, you know, it's not actually that common. It's just because you've got this demonstration in a funny little cohort in the middle of nowhere called Perth in Western Australia, and you know, Armidale. Well, who's ever heard of that? It's really a suburb of Sydney, isn't it? And so we thought, well, look, there's only one way to prove we're right, and that is to do the biggest study we possibly can, and to be sure we're right, and then we'll get this right. So what we did was we decided to make this into a truly national study, and so that's why we called it NEDA. In fact, NEDA, the name NEDA actually comes from Greg Scalia, who's sitting in the audience here, who liked the name, and we agreed with him. So this is where it's come from. So NEDA was the rationale and methodology was published last year in the American Heart Journal. And this is what it looks like. So it's a not-for-profit research organisation. So this is not intended to make money or pay people. It's intended purely for research. And we have a board of directors. We have an independent ethics consultant to make sure that everything we're doing is above board. We have a research committee. We have a steering committee, and we have the PIs. And the steering committee are noted here. I won't go through them by name, but you can see them up on the screen here. And we meet regularly. We meet at the board. We meet in the steering committee regularly, and we go through basically the details of exactly how we're going ahead and doing this massive project. So what do we do with this? Well, we take all identified data. So we include patient names in this, and the reason we do that is so we can link with mortality. And that's a really key part of this. We also take every echo measurement. So every single measurement that's performed in the echo exam and is transferred to the reading software. And we also take all of the interpretive comments. So whatever the echo cardiographer and cardiologist felt was present in that echo is captured by NEDA. We also capture advanced stuff. So if there happens to be GLS done, or if there is some other 3D measurement performed, if that comes across and is in the report, then we will capture that as well. What we don't do is we don't capture echo images, and that was a strategic decision that we made because of the size of the database. We felt it was going to be basically impossible to do this if we captured images as well. So we can do a subset of images, but we don't have images as part of the database. And this is effectively what happens. This is a truly vendor-agnostic system. So the whole point of this is to try to acquire the data from any lab, any vendor, anyone that produces this type of echo data. And so we transform it into our NEDA standard. We have a series of filtering tools that reorders and gets rid of impossible values, removes duplicate studies, and merges identical patients, and then sets everything up into this unique identifier, and then gets into the NEDA database. And then once we do that, we then do a further sanity check to make sure that everything is correct. So so for example, we get rid of all negative values, apart from strain, which of course is negative as it's supposed to be. We check for ranges, make sure we're not like centimetres to metres, transformation accidentally, and we check these things called humanly possible ranges, which is something we've kind of invented. As you probably see on your echo report, sometimes there's impossible values that turn up, and that's okay in an individual echo report, but in a database it's not okay. So we've set a whole bunch of ranges, which you can see on the right hand side, of what we think is the lowest possible number that a human could have when they're staying alive, and the other end is a superhuman who can do what very few other people can do. We're including them too. So, and then we also do sanity checks of this type of thing. So we look to make sure that there are errors. If there are errors from transformation, for example, the height and weight have been put in back to front, then you can see this. So you can see that flashing black circle there. It shows that these are the people where the height and weight were accidentally put in backwards. And so when we do that sort of correction, everything fits exactly as you'd expect. So this is the current status of NEDA. In fact, this is the status of our current mortality linkage. We've actually got another 7 labs that we're just waiting to put the data into, and we don't know exactly how many that will be, but it'll push us up closer to probably a bit over 1.5 million studies. This is on 689,000 individuals, over 1 million studies now, 37 million individual measurements, 9 separate echo vendors, and across the whole of Australia. And we've linked with the National Deaths Index. So we've got ethics approval across the whole country. So this is public hospitals, private hospitals, university, etc. And the information we get is death status, as in alive or dead, the location and date of the death, the primary cause, and the secondary type antecedent causes. And every single analysis we do is based on the STROBE guidelines. So basically, the STROBE is a checklist of 22 items that are regarded as essential for good reporting of observational studies, and every statistical analysis plan we write is based on this. So those of you who are already involved, thank you for your contribution. It's very exciting to have this, and if you're involved in NEDA, then you are automatically an investigator. And if you want to work on the NEDA database, all you have to do is put in a research request, and basically it'll happen, assuming that what you're doing is physically possible with the data. If you're not involved, then we'd encourage you to be involved. And so for a private lab, it's actually very easy. All you need is someone who's authorised to sign the lab consent form. You just sign it and you're done. For public hospitals, a little bit more to it. We need to go through an ethics approval process. We've already got it covered through the Eastern Seaboard National Ethics Process with the RPA as the lead site. And then we have governance approval at each site. And then basically we take a backup copy once everything has been finalised. So I'm now going to show you some really interesting data on left atrium, which is really the purpose of going through all of this. And one of the really I think key things is when you have a small study, the small study will show you what is probably right. And then you show another small study and that shows you what's probably right. The trouble is when you get a whole bunch of small studies together, it doesn't necessarily confirm that that is in fact the truth. And so when you have very big data, you get some very, sometimes very surprising results. So this is our previous data cut, which we published at presented at the ESC last year. So this is on 331,000 individuals aged over 18. I won't go through the details just in the interest of time, but most people had a normal left atrial volume of less than 34 mils per metre squared. A smaller number had a mildly enlarged, moderately enlarged, and then severely enlarged. Notice how many people had a severely enlarged left atrium, quite more than you would have thought. Now, here's the thing. If you look at this, these are the various different ways of measuring left atrial size. Look at this one here, the systolic diameter. They're almost, there is a separation there, but it's not very impressive. So you can use it. But what's much better is this, which is the left atrial volume index. And you can see there's a really clear separation between 31 and 39 mils per metre squared. Now, the expected characteristics, those with the smallest left atrium were younger, and the older people had the larger left atrium, and also people with the largest left atrium tended to have more diastolic dysfunction. No great surprise there. But there was this huge separation between those who were normal and the light blue, less than 21, the red, which is 22 to 26, and the green, which is 27 to 31, all superimposed each other, as you'd expect. And then in this 31 to 39, there was a clear separation. So we knew that the threshold of mortality had to be in that orange line somewhere. So we decided to cut it down further. And the beauty of big data here is that we can go more and more granular, and we can cut it down to smaller and smaller and finer cuts. So we did this. We did a sub-analysis of all of those in the orange line. And what we found was this, and this is really cutting it down finely. And you can see there's an obvious separation point right there. So this is in females, it's right on 34, what a surprise. And then let's go to the next one, males, exactly the same thing, but in fact it's at 35, not 34. So there's, and then if you go above that cut point, so this is taking it the other way from that threshold up to the highest level, you can see that there is a relentless and progressive increase in mortality above that threshold. And so if we now put this into the guidelines, the hazard ratio of mild enlargement is 1.3. The hazard ratio of moderate enlargement is 1.4 for males and 1.6 for females, and then double effectively when it hits severe. So it's really interesting that we can get this level of granularity. So the bottom line is the threshold of mortality starts at 34 for males and 35 for females. So, and we can use this from a practical point of view. This person has a left atrial volume index of 56, so their mortality is increased by a factor of 2.2 just from that number alone. So, of course, as Lisa mentioned, there's the risk of left atrial, the risk of cardiometabolic stroke is associated with left atrial volume, and we know that that's related to thrombus in the left atrial appendage. You'll hear some interesting stuff from Pragnesh Joshi later on today, and I'm giving you a snapshot here. This is our data for the Cardiac Society, which is using total thoracoscopic insertion of the atrial clip. But just to finish up, just for a bit of fun, sometimes it's just too hard. Thank you very much.